Shiva, we are live now.
Thank you, Dr. Ajay. So, good evening, our esteemed guest. Welcome to Radiology workshop on chest radiology in current scenario. My name is Shiva Srivastava, and I would like to take this opportunity to talk to you about Mankind Pharma. "2020 is the year when Mankind successfully completed 25 years of its journey in the pharma industry. And in all these successful years, our vision has been to become the most admired Indian pharma company. And keeping that vision in mind, today Mankind is a fully integrated India pharmaceutical company with a great success over a wide range of prescription and OTC products. Within the Indian market, we are at number one in prescription written and has achieved fourth rank based on the top line revenue. At Mankind, we have 19 WHO FDA compliant manufacturing units, and our global presence is in 34 countries, including US. In the time of COVID, Mankind Pharma actively contributed to PM CARES Fund. We always strive to improve the quality of life, and towards that, our three basic principles of serving life is affordability, reach, and quality. Over the years, we have well represented ourselves in almost all major therapeutic areas with leadership. Mankind Pharma has its own research and development capabilities where we aim at developing novel and differentiating scientific solutions through innovative approach. And with this, we thank you for your continuous support and encouragement for us. Now with this, I hand over this session to Dr. Prashant for further proceedings.
Thank you, Shiva. And welcome again, everyone, to this another session of Radiology workshop with our esteemed guest speaker, Dr. Rajul Rastogi, sir. Dr. Rastogi, sir, is the Associate Professor, Department of Radiodiagnosis at Tirthankar Mahavir Medical College and Research Center. He has more than 150 research paper publications in international journals and more than 50 chapters in 15 textbooks. He has also presented more than 20 research papers at national and international forums. He has been a faculty and chairperson to more than 50 CME and conferences and is a reviewer, and he is also the reviewer and editorial board member of more than 60 international journals. He has been awarded as the Young Scientist Dr. V.P. Lakhanpal Gold Medal by Indian College of Radiology and Imaging. Also been awarded with K.M. Rai Memorial Oration Award by Indian Radiological Imaging Association. Recently, he has received Rising Star Award in Healthcare by Times of India Group. So now, sir, I welcome you once again, Dr. Rajul Rastogi, sir. Please, sir.
Yeah, thank you, Dr. Prashant, for such a nice introduction. So I welcome all the viewers and the listeners to this new lecture in the series of chest radiology and the in current scenario. So let me share my screen. So is my screen visible?
Yes, sir, it is visible. Just put it into full screen mode, sir.
Yeah. So now it's okay?
Yes, sir.
Okay. So today we'll be discussing mainly the thoracic CT or the chest CT in the cases of the pyogenic and viral pneumonias, and we will see the different type of presentation in radiology and how we can differentiate this from the current COVID-19 pneumonias. What are the specific or characteristic signs, and in addition there will be in the middle there will be brain teasers in the form of quiz questions. So now coming on to the normal anatomy of the chest CT, we will spend a few minutes on this. All of us know that the CT thorax is one of the most common investigation when the patients are being evaluated for any disease where the chest X-ray is not adequate or the clinical radiological concordance is not there. But we should all understand that how to interpret or how to visualize these chest CTs. So you will see that the chest CTs come in two different windows that we call windowing and centering in terms of our CT terminology. So that is a lung window. What is a lung window? As the name suggests, that the lung window shows the internal architecture of the lung, and this is the prime window that we should use to look at the lung abnormality. So on the left you have one image at the level of the upper trachea where we can see the apices of both the lungs, and you don't need to look anything outside the lung. It is purely and purely to visualize the lung parenchyma and what all bright structures which are branching that we see correspond to the vessels, whereas the lucent structures which are lying adjacent to the vessels are the bronchi centrally, and as we go towards the periphery they will correspond to the bronchioles. A good 128 slice to 256 slice CT will be able to show at least 6 to 8 generations of the bronchi and bronchioles, but still there will be at least 1 centimeter of the periphery of the lung where we would not be able to see the vessels and the bronchioles that clearly. So how to differentiate between these vessels as arteries and veins? So by virtue of the anatomy, we all know that the arteries branch at 60 degrees or it is an acute angle, whereas the veins, when they are formed by their tributaries, they join at the 90 degrees. So in short, or a thumb rule is, if you see the branching pattern in terms of 60 degrees, then it is an artery. But if it is nearly 90 degrees, think that the two tributaries of the peripheral veins are joining to form the pulmonary vein tributaries. Now, when we look at the lung periphery, the vessels, the bronchi, the trachea, we also look at the fissures because CT is very good in giving us the lobar distribution of the disease, which is very important. While not only we are looking at the etiology, but also the extent of etiology. For example, in COVID-19 pneumonia, we are looking at the scores. So this score is dependent upon the segmental anatomy as well as the lobar anatomy. So in short, we should look for the fissures, and the fissures look something like these faint hyperdense bands or bright bands. This correspond to the oblique fissure. And when we look at the sagittal reconstruction of this lung, it is the left lung, we can see that the oblique fissure is seen as we see it in a gross anatomy. So the CT shows the anatomy of the lungs quite well, and it is almost equivalent to what we see it by our naked eyes. Then after the lung window, we get another window on a thoracic CT that is known as a mediastinal window, and this window is meant to look at the mediastinum. And in the mediastinum, we have got two type of images. One is the non-contrast image and the other is a post-contrast image. So how do we differentiate? I have just kept one image on the left as non-contrast and on the right as post-contrast. So we all know that whenever we give intravenous contrast on chest computed tomography, the contrast lies within the vessel and it brightens up the vessels. So this is how you will be able to differentiate. So this is the arch of aorta, this is the superior vena cava, and this is trachea, and posteriorly there is esophagus. So what you can see is the brighter aorta is a post-contrast image, whereas on the non-contrast image you will see it quite low in density. So this is how you will be able to differentiate between the windows, and among the mediastinal window we have to separate the non-contrast as well as the post-contrast images. Now, what are the signs of the airspace disease? When we are looking at bacterial and the viral pneumonias, we understand that it is all the airspace disease. So there are different type of terms that we use in radiology to indicate the pyogenic or the viral infection of the lung tissue. It is the consolidation, the fluffy opacities, the nodular infiltrates. There is collapse or atelectasis of a segment of a lung, and then there is a ground glass opacity. We will look at the examples in the form of images of each one of them. So coming on first to the consolidation. So what is consolidation? By definition, it is the replacement of the air within the lung tissue by a fluid, which may be pus, which may be blood, or it may be a serous fluid, or it may be just a tumor. So it is replacement of the air by something which is removing all the air from that lung tissue, causing its solidification. So what this is the consolidation. But another classical sign of consolidation is presence of air bronchogram. So what happens is initially the lung tissue, which is lying at the periphery of the lungs or the peripheral subpleural part, initially it undergoes solidification, but by that time there is some air which is still lying in the central bronchi, and these central bronchi are seen traversing this solidified lung, and this is termed as air bronchogram. As it is seen towards the periphery, we can term it as air bronchiogram, and when we see cluster of tiny air spaces, that is known as air asinogram. So this is a chest CT where we see that one part or the anterior segment of the right upper lobe undergoes solidification, and we can see the air bronchogram. Here again, this is a sagittal view. We can see that the anterior segment of the right upper lobe is solidified with air bronchogram. So this is consolidation, and the classical sign is air bronchogram. Now we talked of fluffy and nodular opacities. What are these? So nodular opacities are nothing but tiny nodules. They are round, they can be very tiny, and they should be less than 3 centimeters in size. So we divide them into micronodular, miliary, macronodular. Among the macronodular, there are different type of lesions, and even the nodules can unite to form larger nodules. So when these nodules coalesce or they are lying very close to each other so that the CT cannot differentiate them as two separate nodules, they appear like fluffy opacities. So if we see these lesions, we cannot characterize them either into nodules or into consolidation. So we call them fluffy opacities or cotton wool opacities. Whereas when we can see a well-defined lesion, we can say that these are nodular lesions. So fluffy opacities and nodular opacities, again, these are seen in infective pathologies. It may be bacterial or viral. Then another manifestation of the pneumonias, whether it is pyogenic or viral, it is stream bud pattern. We will find this terminology often being talked of. And what is stream bud pattern? We can see that the respiratory bronchiole gets filled with the pus, and we can see some acinar ducts in the form of, again, opacities, and it appears like tree in bud pattern. So the budding is seen in the branch of a tree. So that is termed as the tree in bud appearance, and this is classically described in infective lesions, but it can often be seen with bronchiectasis or allergic aspergillosis. But the majority of the cases are because of infection only, because ABPA is not that common as compared to the infections. And this picture arises because of the filling of the air spaces, maybe the acinas, respiratory bronchiole, or acinar ducts, or maybe the larger bronchi with mucus or pus. Then at times all these infections are so severe that the body cannot control these infections, and the immune response give rise to complete destruction of the involved lung parenchyma, and this gives rise to cavity. So here what we can see, there is a thick walled area which is only filled with air. So this is cavitation, and this is complete loss of the lung parenchyma, and this will definitely leave some residue. There will not be any complete disappearance of this cavity, and we can see that because of the healing there are some fibrotic stands, there is some desmoplasia here, and it is causing pleural tagging and as well as pulling of the pleura. So this tells us that this lesion is in the healing phase and there is some fibrosis all around it. Another appearance which is seen in the infections of the lung parenchyma are the collapse. So collapse is basically again complete loss of pneumatization of the lung parenchyma, with a difference that there is no air bronchogram. It is very rare to see air bronchogram within a collapse, and if at all it is seen, we should look for the volume loss. So here what we can see, normally this entire mediastinum, this is a mediastinal window, we can see this is the sternum, this is the vertebrae or the spine, and we see that the entire mediastinal structures are pulled towards the right side. Normally they are just to the left of the midline, and because of this volume loss, the entire hemithorax has also collapsed on this side, and we can see that there is pruning of the bronchus, which is actually aerating this uh, right middle lobe. So in this way, we can diagnose or differentiate the consolidation from collapse. So collapse is complete loss of pneumatization, usually no air bronchogram, and there is loss of volume. This loss of volume is very, very important. And if it is because of the mucus plug which may dislodge, so the collapse will change. So suddenly one CT might show complete collapse, and the another CT within a day or two might show complete resolution of the opacity. This can be seen only with collapse, not with consolidations. So when the infection is very severe, it will always leave some or the other sort of complications. So here what we can see, not only there is loss of the volume of the right lung, but there is lot of fluid and lot of cystic spaces, and there are some calcifications which suggest that this is a chronic condition. There is some thickening of the pleura. We can see this bright line which is irregular also, and when we see the lung window, we see air fluid level in this. So this was a case of a complete destruction of the right lung, and this destructive lung parenchyma was secondarily infected to give rise to the pus, and therefore this air filled cavity is showing air fluid level. So this can be seen practically with all the bacterial pneumonias. It is usually not a feature of the viral pneumonia. So whenever the pathogenicity of the bacteria is too high or the immunological response is also high, then this type of destruction of the parenchyma with sequelae will be there. Then once the healing occurs, there can be some nodular lesions which can be pleural based. Here what we can see, there is an obtuse angle. The broader base is towards the pleura, and these are not producing any sort of fibrotic lesion in the adjacent parenchyma, but there will be some bulge on the lung surface, peripheral part of the lung. So these are healed lesions or maybe in the healing phase. We cannot be 100% sure until and unless they do not show any degree of enhancement for which a dual source CT is superior than the single source CTs. At times, the healing occurs by the fibrosis. For example, in this case, we can see there is a lot of fibrosis, there is loss of architecture of this area of the lung parenchyma, there is subpleural fibrosis, it is pulling the pleura towards itself. So this is all a healed lesion. However, it is often said that if any granulomatous lesion leads to this, like tuberculosis in our country is there, so it can still harbor the tubercle bacilli. So reactivation tuberculosis or recrudescent tuberculosis cannot be ruled out. Even when these fibrotic areas are formed which distort the complete architecture of the bronchial tree, so this will lead to retention of the secretions within the peripheral bronchi and bronchioles, and at times they will get infected. The patient will continuously complain of the sputum production, and this will get secondarily infected and give rise to the secondary pyogenic consolidations on this background. So now coming on to the last type of presentation of the various types of pneumonia, specifically the viral pneumonia. So here what we see is, here the lung parenchyma is slightly darker than this parenchyma, and the distribution of the vascular tree is almost similar, but this ill-defined bright area through which we can see the vascular markings is termed as a ground glass haziness. So in short, a ground glass haziness is the opacity of a lung parenchyma through which we can see the major vascular structures. So to differentiate it from consolidation, we should see that in the consolidation, we cannot see the vascular markings and there is air bronchogram, whereas here except for the density or the attenuation of the lung, rest of the things remain absolutely normal. So why does this arise? This is at a very uh, peripheral level, which is beyond the spatial resolution of the CT scanner. So they don't show these areas as nodular infiltrates. Otherwise, if we see such opacity on a single slice CT, it is possible that if you do the same scan on a 128 slice CT, you might see some nodular infiltrate. So basically something which is beyond the resolution of the CT scanners, then it will appear as ground glass opacities. So this is a common feature of all the viral pneumonias and at times in the initial phase of alveolar hemorrhage. So this is a coronal reformatted image, and here what we can see, again ill-defined areas of increased attenuation and interspersed with lung parenchyma of normal attenuation. So this is known as ground glass haziness in mosaic pattern or geographical distribution. Once these GGOs become denser or the disease progresses, it becomes organizing pneumonia. So in the last case, what we saw, there was very subtle ground glass haziness, but here what we can see, the density has increased, and when we see the right hand side image, we see that there is typical consolidation like areas. We can see the air bronchogram as well, but it is not a typical consolidation that we have seen in our previous images. So this is the progression or the evolution of the ground glass opacities into the organizing pneumonia. So the viral pneumonias will progress from the faint GGOs to clear-cut GGOs and then to organizing pneumonias. These organizing pneumonias areas might heal completely, but majority of the time when the areas are larger, they will lead to some sort of scarring in the form of fibrosis, and in that case we will see that there is loss of architecture in that area, there is pulling, there is pleural tagging, and the pleural surface, peripheral pleural surface becomes irregular. So this is a case of a viral pneumonia which has undergone healing, and we see multiple areas of fibrosis and very few and small areas of ground glass haziness. So we have to remember that whenever we are looking at the CTs of viral pneumonias, we have to know how much area is the active disease and how much area has actually undergone fibrosis. So this helps us in further instituting the management and determining the prognosis of the patient. So this is a coronal reformatted image of the same patient, and we can see that there are peripheral areas of the fibrosis, subpleural fibrosis, and there is pleural tagging, and this pleural tagging will definitely be the reason of restricted movement of the lungs, and this patient might suffer from breathing difficulties or pain during the deep breathing. Now coming on to the cases. So this is a case of a patient, young patient, who has presented with high grade fever and also the raised TLC count of around 17,000, and the patient has severe cough with sputum production. The patient's X-ray revealed that there is some ill-defined haziness. We can see some ear bronchogram like picture, and there is dense consolidation in the parahilar location, and this is predominantly in the right upper lobe, and we can see some area which is very lucent and devoid of the lung markings. So when the CT was done in this patient, the lung window showed again the better for findings, and we can see that there is an area of loss of pneumatization of the predominantly the anterior segment of the right upper lobe. Again, there is one area where we cannot see the lung tissue, and there are some ear bronchogram like shadows. But when the mediastinal window was seen, what we could see is there is definitely some lung parenchyma, but the peripheral part is very, very hypodense. It is not enhancing. It's a post-contrast image. We can look at the vessels, they are bright. So this lung, which is actually enhancing, it is a viable tissue, whereas the lung parenchyma, which has not enhancing, is a non-viable tissue. So this means this hypodense area is actually has undergone necrosis, and this is the air within that necrotic area. So this necrosis can be because of the ischemia or maybe because of the infection. We cannot differentiate it just on the presence of air, because whenever the lung parenchyma gets destroyed, ultimately all the air will collect at one place and it will give rise to the air fluid level. So here this is a airway image of the patient. So what we can see, this area has lost its viability, and this large defect is seen in the anterior segment of the right upper lobe. Another case, which is a case of a necrotizing pneumonia. So necrotizing pneumonia is specifically caused by certain bacteria like Klebsiella, Pseudomonas, which are highly pathogenic, and they escape the immunological mechanism or the defense mechanism because of the capsule around the bacteria. So in this case here, what we can see, there is some large opacity which is heterogeneous, some air is seen within it, but what we can see is there is superior bulging of the minor fissures. So there is some expansion, and when we see the CT topogram, we can actually compare it with the chest X-ray, but the lucency is too high because of some ongoing destruction of the lung parenchyma. So in this case, when the mediastinal window was seen, so we could see that there is a enhancing lung parenchyma, but there are multiple areas where there is no lung parenchyma, and there is some sort of liquefaction also. It is, this area is not enhancing, and definitely this area is actually causing expansion. So whenever there is expansion, increased volume in a situation where there is necrosis as well, so think of necrotizing pneumonias, and this is very common with the Klebsiella and Pseudomonas aeruginosa. So this necrotizing pneumonia is different from the consolidation with necrosis. When a long-standing consolidation is there which is not being treated, or the body is not able to overcome the cause for it, so it undergoes aseptic necrosis, and that is known as consolidation with necrosis. Whereas when there is necrotizing pneumonia, so from the very first day there is destruction of the tissue, and this destruction is massive. It is like we can see there is a large lobar consolidation with a large area of destruction, and we cannot see any normal architecture of the lung. So this is necrotizing pneumonia. When we did the multiplanar, we could see that there is this is the minor fissure, this is the oblique fissure, and what we can see, there is a small element of the necrotic lung tissue which is left, and rest is all air, and there is expansion. We can see the bulging of fissures on both the sides. So this airway window shows that there is a complete defect, and in the center there is just a necrotic ball of the lung parenchyma, and rest of the parenchyma is completely destroyed. So now we have come to the first quiz of this webinar. So this is a chest X-ray of patient. This is the lung window of the same patient, and write the probable diagnosis. What is the probable diagnosis? We'll take 30 seconds to note down the diagnosis, and we will discuss the answer to these questions in the last. So it's a simple case. Just on the basis of the X-ray and CT, we can decide what type of consolidation it is and what is the most probable etiology to this. So I hope everybody must have recorded their response, and we will go ahead with our discussion. So this is quiz number 2. Here, this is the chest X-ray of the patient, and this is the mediastinal window of the same patient. So note down your response, and we will discuss the answer to this quiz as well in the last. I hope everybody have recorded their response. Going ahead with the discussion. Now, we are all aware that in this COVID-19 pandemic, a lot of people are coming with their breathing difficulties, and at times what type of findings that we see on the chest X-ray are what we are seeing on this. We are not able to see the bronchovascular markings clearly. This is a hazy X-ray. Patient is very dyspneic, and we can see that there is ground glass haziness similar to what we saw on the CT. So this can be an early sign of the viral pneumonias. This patient initially was not on ventilator. Then as the disease progressed, we can see the density of the haziness has increased. The right lung is involved almost more than half. The lucency has gone, and the patient is now on intubation. So this was a case of the viral pneumonias. We can see early ground glass haziness, and the dense haziness or the density of the GGO is increasing, going towards more of the organizing pneumonias. Another patient of the viral pneumonia, where we can see that there are ill-defined infiltrative lesions or areas of ground glass haziness in this left middle and lower zone, some patchy opacities which correspond to the consolidation. In the same patient, an X-ray a day apart shows more massive involvement. However, there was one opacity lying in the right lower zone which has disappeared. So again, if the opacity appears and disappears fast, it might be because of just a collapse. So as I've already explained, that at times the collapse is just because of the mucus plugs, and at times because of the bronchial washing, or maybe because of good ventilation that is being given artificially, these mucus plugs get dislodged, and that area again gets aerated. But if we see the severity, the lucency of the lung on both these sides have actually reduced, so the patient has become more severe in terms of the clinical terminology. And I showed you so many cases, one CT of the fibrosis secondary to viral pneumonia. So here what we can see, the same picture on the chest X-ray. But remember, this type of fibrosis can be secondary to the tubercular pneumonias also. So I am intentionally showing these X-rays because we never get a CT done directly. We always look at the chest X-rays first and then decide whether this patient needs a CT thorax or not. So if this is the first X-ray at the time of presentation, think that this is a sequel to a previous disease. However, if this X-ray comes a week after the presentation, it might represent the fibrosis secondary to the viral pneumonias. So in viral pneumonias, what is very important is the X-ray presentation at the time of the onset of the symptoms. So if you see ground glass haziness at the time of symptoms, you know that this haziness is probably because of the viral pneumonia or maybe because of the acute disease. However, if you see such a picture which corresponds to the fibrosis at the first presentation, so probably the patient is having dyspnea or respiratory difficulty because of the some other disease and he has presented to us now. So this needs to be looked in detail. So now what are the actual manifestations of the viral pneumonias on the chest CT? So we have discussed that there are GGOs. So similar to GGOs on the X-ray, or actually the GGOs were first described on CT itself, and then as the digital X-rays came in this era of electronic medical industry, so this GGO has also become a part of the routine day-to-day X-rays. But on CT again, what we can see is ground glass haziness. We can see the vessels through them. So this is not consolidation. We are not seeing any air bronchogram. So this is ground glass haziness. This ground glass haziness can be unilateral, as in this case, or it can be bilateral. It can be bilaterally symmetrical in the two lobes, or it can be asymmetrical in the two lungs. But usually viral pneumonias will affect both the lungs to a varying degree, and the wire bases are more commonly involved. Peripheral part is more commonly involved. Here what we can see is this ground glass haziness is reaching up to the pleural surface, but actually there is a thin rim of the lucent lung which tells us that it is not a pleural or a subpleural process. It is actually progressing from the center towards the periphery. Another sign of the viral pneumonias is, as we have seen, that the GGOs become denser and ultimately they might progress to some consolidation. So in this case, the peripheral GGOs have progressed to consolidation and there is some minimal pleural effusion. Pleural effusion are usually not a sign of viral pneumonias, but they may be seen. Whenever seen, they are quite minimal and it is free. Whereas in the bacterial pneumonias, the pleural effusion is much larger and it is often separated because of the presence of the pus. In the viral pneumonias, this fluid, even if it is stabbed, it will be serous in nature. So another case where there are GGOs on both the sides and there is asymmetric consolidation of the bilateral lower lobes. It is higher on the right side. So this is consolidation because I cannot see any vascular marking through it. Although there is no air bronchogram, but there is no loss of volume. There is no loss of volume on either side, so it is likely to be consolidation only. It's not collapse. So this is a case of a typical consolidation that might occur in a viral pneumonia. As I have already explained previously, we can see the air bronchogram, I can see the air bronchulogram and the air asinogram. So in this case, this is an inverted picture of the tree in bud appearance. So normally in the tree in bud appearance, this airway is filled with mucus or pus and the rest of the lung becomes lucent, but it is an inverted image. Here the entire lung gets solidified with loss of air, whereas the airway shows the presence of the air within it. So in this case, what we can see, there is a large consolidation in the right lower lobe with some ground glass haziness in the middle lobe, whereas we can see primarily ground glass haziness with few nodular infiltrates on the other side. So as of viral pneumonias, it is bilateral, although it is asymmetrical. Another case of viral pneumonia where we can see consolidation. and we can see ground glass haziness. And also we can see tree in bud appearance. So by this, we should understand and remember that tree in bud appearance is not only seen with bacterial pneumonias, it can be also seen with viral pneumonias, because it can be just the mucus plug or an inflammatory collection lying within the airways. So it is not classical of TB, it is not classical of other bacteria, and it is not classical for viral etiology. It is classical of infective etiology in majority of the cases. And remember, we are seeing ground glass haziness in almost all cases of viral pneumonias. This GGO, this ground glass haziness is classical for viral pneumonias. If you see only consolidation, it is unlikely to be viral pneumonia. If you see a large ground glass haziness or a small consolidation within it, it is very likely to be a viral pneumonia. So now coming on to the COVID-19 pneumonia, how can we differentiate the COVID-19 pneumonia from the other causes of viral pneumonia or other etiological agents of viral pneumonia? So two classical signs have been described in the literature in the last 1 year. So many papers have been published, and two signs have been found to be characteristic with a high sensitivity and specificity. So these are vascular thickening or dilatation. So what we can see, there is a large area of ground glass haziness, and we can see the dilated vessels. So how we will say what is the diameter, what should be the dimension? So normally, as we go from the hilum towards the periphery, the diameter of all vessels is reduced. However, in this case, what we can see within the ground glass haziness, actually the vessel diameter has increased. There is bulbous enlargement of the vessel. So it is a vascular thickening or dilatation, and this is supposedly caused by the vessel wall destruction secondary to the vasculitis. So there is weakening of the wall and the vessels get dilated. So this has been described with COVID-19 pneumonias. It has not been described with other viral etiological agents. Another sign that has been described is reverse halo sign. So normally, when there is a hyperdensity in the center and there is a less dense halo, so we call it a halo sign. Whereas in the COVID-19 pneumonia, the central lucency surrounded by a zone of the hyperdensity is termed as reverse halo sign, and it has been described because of the alveolar hemorrhage or more in high inflammatory response in the surrounding area. So this is a reverse halo sign. It is commonly seen at the periphery of the lung, and this is again quite characteristic, though not pathognomonic of COVID-19 pneumonia, but it is quite characteristic of the COVID-19 pneumonia. So we have seen two characteristic signs of COVID-19 pneumonia. One is vascular thickening or dilatation, and the other is the reverse halo sign. So now, whenever you are seeing the CT thorax reports in the COVID positive patients or patients who are suspected to be cases of the COVID-19 pneumonia, so you must be seeing the CORADS category. So what is CORADS category? CORADS category corresponds to this level of suspicion for pulmonary involvement to be secondary to COVID-19. So actually it is not diagnosing the disease, it is not saying that telling us the severity of the disease, it is just telling the degree of suspicion that this pulmonary involvement can be COVID-19 pneumonia. So it has been given from 0 to 6. 6 is already proven case, 0 is not interpretable CT, and based on whether the suspicion is very low, equivocal, high and very high, we can assign this category as 1, 2, 3, 4, 5. And this is only for COVID-19 suspicion. It does not say that the CT becomes the specific modality to say that it is COVID-19 pneumonia. So these findings have to be seen in the context of the symptoms, the contact. So everything has to be taken into account. But based on the radiological picture, we can give this CORADS category. So what are the typical features which suggest that there is a very high possibility of COVID-19 pneumonia? As we have discussed, ground glass opacities, because these are classical for viral pneumonias with or without consolidation. These are not mandatory features, and it should be in regions close to visceral pleural surfaces, although sparing can be there. So it should not be immediately subpleural, but yes, closer to the visceral pleura. And another important is it is multifocal and bilateral. So usually bacterial pneumonias are not multifocal. The exception is tuberculosis, and also bilateral. So bilateral multifocal ground glass opacities in peripheral distribution, it quite uh, classical or characteristic for COVID-19 pneumonias. And how do you describe these ground glass regions? They should have unsharp demarcation. They can have half rounded shape. So they should not correspond to the segment. They should not correspond to the lobes, because it can be just the evolution of the consolidation. There can maybe crazy pelvic pattern may be there, and there can be patterns which are compatible with organizing pneumonias. Thickened vessels and parenchymal abnormalities can also be taken as confirmatory patterns that we have all seen in our previous images. Now comes the CT severity score. Once I have a high suspicion, then I would like to give this severity of the lung involvement. In cases where the patient is already a known or RT-PCR proven case of COVID-19, so then this CT severity score will tell us with how much lung involvement is there, how much lung destruction is there by this CT severity score. So every lobe, there are three lobes in the right lung, two lobes in the left lung, and each lobe will be given a score based on how much percentage of that segment of that lobe is involved by the ground glass haziness or consolidation. So if a score of 1 is given when the involvement is less than 5%, a score of 2 when the involvement is 5 to 25%. In this way, if the lung is the lobe is involved to more than 75% of its parenchyma, then we will say that it is a 5 score. And 0 score is given if there is no lung lobar involvement in any lung. So maximal score will be 5 of one lobe. So out of 5, for 5 lobes, the maximum score can be 25. And based on multiple studies, it has been found that a CT score of greater than or equal to 18 is highly predictive of patient's mortality in short-term follow-up. So this has been based on a lot of studies that are coming in the recent journals, all prestigious journals. So they say when the CT severity score is greater than or equal to 18, in spite of our all efforts, the patient has a high rate of mortality in short term within a week or two. So what is the take home message from all these what we have discussed? The viral pneumonias, specifically the COVID-2, has typical and characteristic patterns on CT thorax, yet because of its significant overlap of its features, CT thorax cannot be used as a screening tool. So why, if it cannot be used as a screening tool, what is the value of this? Recognition of these patterns may be characteristic or more commonly seen with one virus family, which will not only aid in initiating early antiviral therapy, but will also obviate the injudicious use of antibiotic therapy. So if we are able to characterize that this is because the lungs have more of GGOs rather than consolidation, so it is a viral pneumonia, so I can avoid antibiotics, or even if I give prophylactic antibiotics, that might not be the most broad spectrum one. And if at all I am looking at the viral disease, supposing I know that this pattern is seen with the SARS family, so I can use the drugs that have been advocated for treating such viral family. COVID-19 pneumonia is characteristically diffuse, it is bilateral, and peripheral GGOs are there. They may progress to consolidation, and we may see the vascular thickening within GGOs or reverse halo sign. These are the two signs described as being characteristic. A combination of central and peripheral distribution of GGO in consolidation with pleural effusion is commoner with non-COVID disease. So if we see the broad difference between the two, so central and peripheral, if both are involved, unlikely to be COVID pneumonia. If pleural effusion is there, it is unlikely to be COVID pneumonia. However, very few cases of pleural effusion have been seen with the COVID pneumonias as well. So all those who are more interested in reading how to differentiate COVID-19 pneumonias from other pneumonias are most welcome to visit this journal page, where we have published one review article describing the features that can characteristically differentiate the COVID-19 pneumonia from other viral pneumonias. So now we have reached our quiz 3. So where we can see the lung windows in the form of two images, and you have to characterize which pneumonia is this, whether it is bacterial or viral, and if viral, whether it is COVID or non-COVID. And please record your response. We will discuss these cases one by one. The last quiz, the left hand side image shows the chest x-ray, and the right hand side image of the same patient in the lung window. So again, you have to categorize this into bacterial or viral pneumonia, and if viral, whether it is COVID or non-COVID pneumonia. Please record your response so that we can discuss after this quiz. So I hope everybody is ready with their answers. Now we will discuss the answers to all the 4 quizzes. So the first case was this. Here the chest X-ray shows an almost near complete opacification of the right upper lobe with some air bronchogram. So this appears to be consolidation from the X-ray. And when we look at the lung window, we could see that the posterior segment of the right upper lobe is actually completely non-pneumatized, and we can see the air bronchogram. There is no obstruction to say that it is an obstructive cause of pneumonia. So this was a case of pyogenic consolidation in posterior segment of the right upper lobe. So this type of consolidation will not occur in viral pneumonias because there is no other lesion and there is no GGO here. Now this is a case where we could see a fairly well-defined opacity, which is usually not seen with consolidation. When the CT scan was done, we could see that there is a thin walled cavity which is showing air in the non-dependent part, and there is some dense fluid which is lying in the lower part of the cavity. So this corresponds to the air fluid level. It was a lung abscess in the left upper lobe. So whenever the immunity fails to curtail this infection, so there may be complete destruction of the parenchyma with pus formation. So this is seen with pyogenic organisms. So this is a case of a lung pneumonia, lung abscess. Now here what we can see is there is near symmetric ground glass haziness. Here on this side in the right upper lobe, it is more dense than the left side, and in the lower part, that is the middle lobe. So this is the lateral segment of the right middle lobe, which is nearly consolidated, although we can see the peripheral ground glass haziness. In the left lung, we can also see the ground glass haziness as well as in the left lingular lobe. So this was a case of consolidation with GGO, that is secondary to viral pneumonias. How to differentiate whether it is a COVID-19 pneumonia or not? So remember what we have discussed is it should not be both central and peripheral. Here what we can see, the opacity is extending from central to peripheral, although it is bilateral, multifocal, but it is both central and peripheral. Whereas what is characteristic of COVID-19, it is peripheral opacities. And if at all, we can see the reverse halo sign or vascular thickening. This is another patient where not much is seen, but some ground glass haziness, some opacities are seen on both the sides, more on the right side. When we look at the lung window in this patient, we see areas which are more dense than ground glass haziness. Actually, this is organizing pneumonia. Here also we can see the organizing pneumonia. So remember, whatever we have seen in the viral pneumonias, or rather the COVID-19 pneumonias, we see that there is relative sparing of the subpleural region. Here, what you can see is that even though there is ground glass haziness, it is reaching up to the periphery. And we can see, although it is multifocal, again, it is more of organizing type of pneumonia, which is usually not seen in early stages. This will be a progression when we are looking at COVID-19 pneumonias. And within the opacity, we are not seeing any vascular thickening or a reverse halo sign. So it was a case of organizing pneumonia with GGO, which was non-COVID in nature. So remember, it will be not always possible just on the basis of CT that we can differentiate whether it is COVID-19 pneumonia or not. We have to look at the serial X-rays if at all they are available, if at all the multiple HRCTs are available, and also the clinical background. If the patient is already proven case of the COVID-19 pneumonia, then for all practical purposes, we will have to consider even these peripheral opacities as the COVID-19 pneumonias or organizing pneumonia secondary to COVID pneumonia. So the clinical background coupled with our CTs become more specific, and the role of CT is not for diagnosis, it is basically to determine the extent of the lung involvement and to prognosticate the patient. This is very important, and this is the basis of the chest CTs in the COVID-19 pneumonias. So thank you very much for this patient hearing. Thank you.
Thank you, sir. Again, sir, I mean, it was really wonderful lecture, sir. And I hope, I really believe, I mean, all the doubts and all the doubts related to CT chest and the ultrasound to our audience have been clear, sir. Dear audience, if you have any query, any questions, you can please put in the chat box. We will wait for 5 minutes. And if you have any queries, you can please put in the chat box.
So the message should be clear. CT is not for diagnosis. It is not a screening tool. It is only to determine the severity of the lung involvement. Many a times when in the early stages of the disease, RT-PCR may be negative. In such cases, CT might play some role in diagnosis because clinically the patient either has a very strong history of contact with the COVID patient or has all classical signs, or maybe antibody positive, antigen positive, but it has to be some basis for which we take all the lung findings to be as COVID pneumonia.
Thank you, sir. I guess, sir, so there are no further questions this time. I guess everything is clear to all the audience.
So if I am able to give this message of injudicious use of CT should be avoided, so my job is done.
Definitely, sir. Definitely. So, sir, in case if any of our attendees, doctors, I mean, they have any queries, I mean, later on, so we can connect with you, sir. Is that right?
Okay, okay, no issues.
Yeah. So, thank you, sir. On behalf of Mankind Pharma, I really thank you for all these workshops on radiology. and how beautifully you have explained everything. I mean, started with chest X-rays and then CT scan and ultrasound, and really our doctors who have attended these workshops, they definitely have liked it. And I mean, the feedbacks which we are getting, sir, definitely they liked it, and yes, it will help them in better making better diagnosis at clinic also, sir. So thank you, sir. Thank you very
Thank
much.
you very much. Thank you very much.
Thank you, sir.